I want to let you know about some changes that we made to the Advanced Airway Management Policy. Now, in the past, we've put a lot of emphasis on the use of the supraglottic airway as a first-line option. We want to make it clear that this is only in cases where the patient has a Cormack-Lehane grade of 3 or 4. If you can perform endotracheal intubation during chest compressions, this is still the gold standard and should be used. All right, we're going to go a little bit more in depth into the CPAP policy. Again, we have Dr. Jocelyn Freeman-Garrick and Mike Jacobs, another pre-hospital care coordinator with Alameda County EMS.
Continuous positive airway pressure, CPAP. I'm excited about this policy for 2011 because we're expanding the scope. Prior, you were using it for congestive heart failure. Now we're using it for COPD, asthma, any patient in severe respiratory distress, CPAP is indicated. You're expanding the scope because that's how we're using it in the receiving facilities. When you bring a patient in with severe respiratory distress from asthma or COPD, most of the receiving facilities are putting BiPAP on those patients. So not only in heart failure, but with COPD and asthma, it works. Why does it work in all of these conditions? You know, when you have a patient with COPD, they have stiff lungs, they reduce the minute ventilation, they start to retain carbon dioxide because they're working against a harder system. They're trapping air in the alveoli past the bronchioles. So why does CPAP work for all of these conditions? COPD, heart failure, asthma, any patient with severe respiratory distress. For the 3 conditions that I just mentioned, it's primarily because of the positive airway pressure we're able to deliver. With COPD, the patient has stiff lungs, they end up with tight bronchioles, they get air trapping in the alveoli. The patient then starts to retain carbon dioxide because they're not able to exhale past the stiff lungs and their minute ventilation goes down. With asthma, there's bronchospasm in the upper airways as well as in the bronchioles. And finally, with heart failure, dysfunction has increased. The patient isn't able to pump blood effectively, and that increases liquid in the lungs, which causes a prevention of oxygen transmission from the blood to the lungs. CPAP bypasses this by the positive airway pressure. It combats the stiff lung as well as the bronchospasm to expand the airway and give that positive pressure to distend the alveoli and allow the patient to expire the carbon dioxide and to prevent CO2 narcosis.
When using CPAP to deliver positive pressure to a patient with severe reactive airway, there's one clinical complication you should be aware of and look for. It's something called dynamic hyperinflation, better known as distal air trapping. It's where a patient with severe bronchospasm, severe reactive airway, can actually get X amount of air in and be unable to get the same amount out, building greater pressures distally and possibly even developing a pneumothorax. This could end up unilateral or bilateral, and you need to keep an eye on this because you may end up having to decompress this patient if they can't get the air out.
Finally, don't forget about hypotension. It's a minimal contraindication, but you still have to keep it in mind. It's more a side effect than a contraindication. So if a patient has a blood pressure about 100 over palp, you should watch it during transport. If it's 90 or over palp, you shouldn't give it. But usually these patients aren't hypotensive, they're hypertensive because they're in distress. But if you have a patient with a borderline blood pressure, 100 over palp, you can give it, especially if respiratory is the primary complaint. But you have to watch the blood pressure during transport. The name Cardiac Receiving Center for 2011 is being changed to STEMI Center. It's a major change because when we started this process of transmitting EKGs from the field and transporting patients who could have acute myocardial infarction directly to our STEMI receiving centers, they're getting a lot of patients who aren't meeting the criteria of an acute myocardial infarction. The indication, as the policy reads, is only for people with acute myocardial infarction based on the paramedic judgment when you're interpreting the EKG or when the EKG reads acute MI and the symptoms correlate with that. The reason for that is based on the Crusade trial, Ascent, and Finesse, the American Heart Association guidelines for acute MI, emergent cath is indicated and PCI is preferred for acute myocardial infarction. There's a whole continuum of acute coronary syndrome or ischemia without infarction that we see more often. those patients don't meet criteria and should not be transported to a STEMI center. Those patients often do better when they go to their home facility, where they have all of their records, where they know the patient, where they know what they've already received. And if catheterization is indicated, if they get that within 48 to 72 hours, you're doing them better justice. Most of the patients with non-STEMIs, for example, or who rule in with positive tropes and just have some ST depressions, as another example, they often have to be medically stabilized in a cardiac coronary unit first for the first 24 to 48 hours, and then they're arranged for PCI if it's indicated. The other thing I want to talk about with the policy change is if you do have someone with an acute MI, if you have somebody who has an EKG that reads acute myocardial infarction, please transmit it from the field. The STEMI centers are activating their teams as well. They need to know that you have someone with acute MI en route, and if possible, if you can get the age of the person, their correct name and birth date when you're calling them to verify that they have the EKG and you're en route, that really helps the continuity of care. Finally, if you have a patient post a cardiac arrest and after they had a witness VFib VTAC arrest or PEA and you resuscitated them and get return of spontaneous circulation, don't forget to get the EKG. This is mandatory. Get an EKG post-arrest when you have return of spontaneous circulation. Then, if that patient is showing signs of an ST elevation MI, transport them to the closest STEMI center. This is pivotal because you're possibly improving survivability in this patient. They've done studies, as an example, at Harbor in Seattle, Washington, where patients over the last 5 years who have a witness VFib VTAC arrest, when EMS transports those patients to a STEMI who then have ST elevation MI on the EKG, those patients are surviving. Up to 60% of them survive after a witness arrest. So, to summarize, please transmit the EKGs from the field, notify the STEMI centers that you're en route, and get the documented information that you need per the policy. After an arrest, don't forget to get the EKG, especially in VFib, VTAC witness arrest.
In order to stay at the forefront of pre-hospital emergency care, we're introducing the use of tourniquets and hemostatic agents into our policies. Here's Jim Morrissey, a pre-hospital care coordinator with Alameda County EMS, to give us some science behind the use of tourniquets, as well as the indications that you will be using these tourniquets with.
I'm going to be talking to you about hemorrhage control, tourniquets, and also hemostatic agents. A review on hemorrhage control. We strongly emphasize the use of well-aimed direct pressure, and that really means to visualize the bleeding source. So get those scissors out, get that personal protective equipment on, and make sure you find the bleeder and where it's coming from. The other tools that we have on our disposal, pressure points, elevation, are certainly worth considering for effect. A new tool we're adding to the arsenal will be tourniquets. And unfortunately, tourniquets have an undeserved bad reputation. The military has been successfully using tourniquets for decades, if not centuries. And unfortunately, the experiences in Iraq and Afghanistan and the loss of life there has brought up the idea of tourniquets again. The military has shown that through studies and research, significant survivals from an immediate and aggressive use of tourniquet on medical personnel who are injured in the field. The Army's Institute of Surgical Research then went a layer deeper and looked at all of the different tourniquets that are out there on the market and put them through rigorous testing. The one that they approve, as we do as well in Alameda County, is the CAT tourniquet, the Combat Applications Tourniquet. That's not to say other tourniquets don't do their job, and would certainly be interested in looking at those in the future. But for now, we're happy to implement a tool that we know will work for our medics and EMTs in the field. And by the way, this is not just an ALS procedure, but EMTs as well can use tourniquets in the course of their duties. Tourniquets can be used as an adjunct in addition to the direct pressure that we'll be implementing on limbs. We're talking about arms and legs, but certainly in a stressful situation with multiple gunshot wounds or airway problems, we advocate the use of going to a tourniquet early and aggressive if need be to get the limb bleeding under control. Certainly we would want one to document the time that is put in place, and we'll go into some more detail in another section on the actual indications and technical applications of a tourniquet. The other device, or actually the tool and policy we'll be implementing, is the use of hemostatic agents to also help with with hemorrhage control in addition to direct pressure and the other tools that we have. The advantage of the quick clot, by the way, is the tool that we'll be approving for Alameda County, is an optional skill that can be used by only ALS personnel, but the advantage is that it can be used for injuries and bleeding that are not strictly limited to the limbs. So bleeding around the torso, the abdomen, the neck, whatnot, these hemostatic agents can be a great benefit to assist in the bleeding control to get that patient stabilized in the field before transport.
Next, we have Officer Chris WAITE of the Berkeley Police Department and firefighter David Rivers to take us step-by-step through the placement of a tourniquet.
Today we'll be demonstrating the application of the Combat Application Tourniquet, or CAT. The CAT we are using today is black. The one used by Alameda County will be orange. When the CAT comes packaged, it will be packaged like this in clear plastic. The first step in the use of the Combat Applied Tourniquet is have one of your lifesavers applying manual pressure to the wound site and maintaining that pressure. The second step will be for the second lifesaver to open the tourniquet. It will be unfolded, pull the Velcro loose. When the tourniquet comes packaged, it comes fed through one of the buckles. You will want to feed it through the second buckle. The next step will be opening it up wide enough that it can pass over the extremity that you want to put it on. You then pass it over the extremity at least 2 to 3 inches above the site of the wound. You then pull the strap tight. The tighter you can pull the strap now, the easier it will be when you try to apply the windlass. Understand that you're going to want to try to get firm pressure with just the Velcro strap. Once you've completed that, you can start turning the windlass. You continue to turn the windlass to apply pressure to the wound until you have occluded all blood flow past the wound site. Once you've applied the tourniquet windlass into the clip, you take a distal pulse. If no distal pulse is present, you have proper occlusion of the wound, of the artery. If you still feel a pulse, go ahead and tighten down the windlass 1 to 2 more turns. In our case, we have occluded the blood flow. Next step for the upper extremity wound is to pass the remaining strap over the windlass and affix it to the back part of the strap. The final step is to lock down the windlass using the Velcro tab here. Once you have completed all that, the most important step now is to note the time the tourniquet was applied. This will be important for staff in the ED so they know how long blood has been stopped from the wound distal to the tourniquet. That concludes the application of the CAT tourniquet to an upper extremity wound.